So welcome everyone. My name is Marisette Hassan, and I am the program coordinator for the South Carolina Coalition for the Care for the Seriously Ill. And you see our logo there that says CSI. That is a mouthful, so that's why we call it CSI. We're doing a deep dive into all things serious illness care across the state of South Carolina. And so every year we have this annual virtual symposium. We are thrilled that 86 people have already registered for this and still counting. And so we know that every day we're going to have an amazing time. I wanted to just take a moment to kind of go through the schedule this week. This is sort of a noonday event today through Friday, and you'll see our topics through today. We're going to have Dr. Christina McDaniel with us, really talking about the integrative oncology palliative care and the momentum that they are seeing there at MUSC across the state. We also this year, our committee wanted to really look at not only adults, but pediatrics, and so pediatric patients as well. And so for the rest of the week, we will have panel presentations from our esteemed colleagues, really looking at oncology care for adults and pediatrics and survivorship. And then on Thursday, we'll be looking at what are those resources that are available for those populations and their caregivers. And then on Friday, we are going to be really diving into holistic pain management from a clinical physical perspective, but also looking at spiritual pain and existential pain, emotional pain, and how we deal with that as well. Next slide, Jessica. So it's going to be a power pack week, and we hope that you can join us. We will be recording the sessions, as we said. For those of you who are new and do not know anything about CSI, we are a collection of health systems, payers, community stakeholders, a coalition that is backed by Health Sciences Health Innovation Group, which is one of our premier health information exchange organizations in South Carolina and in North Carolina. We were established in 2010, and in those early years, our main focus was really looking at post. And we were able to, after working through a few pilot counties with DHEC, we were able to get post passed in 2019. And so it is recognized statewide. Although COVID happened in 2020, we still have some work to do to educate. But we do have on our website a virtual online academy that really walks people through the post form and how you engage in those conversations. The coalition meets the third Wednesday of every month from 2 to 3:30, and we would love for you to connect with us. We'll be sending out information every month. We let you know what the topic is, and it's usually everything around the serious illness care continuum. We do have a couple of robust committees, and one of them that really has piqued our interest is really looking at the palliative care score ranking that comes out with CAPC. We are a member of CAPC, and so we're able to have access to them. And so we're looking at how can we get the South Carolina score ranking to the next point. Right now we're at 2, and we want to get all the way up to 5. So we're in the middle of the pack. And our committee is made up of health providers, hospices, palliative care organizations, et cetera, really looking at the 5 domains and where can we make some inroads. And then last but not least, we do a lot of education and training for not only clinicians about how to have conversations, but also doing work in community with faith communities, outreach. This month, as we go to the next slide, is South Carolina. Governor McMaster always puts out a proclamation for Healthcare Decisions Month. And so I know many of you last week, Healthcare Decisions Day for a national was on Thursday. And I know many of you have been doing things not only with your staff, but also with your community members. And we're also available to do those things in community as well. I had an opportunity to be out on Saturday at a women's conference, having one-on-one conversations and giving out packets of information to women. As you know, a lot of times decision makers in the home, it starts with the women when it comes to these health issues. And so I want to encourage you to get out and to share. Now we're getting ready to go into our time today with Dr. Christina, but I wanted to take a moment to introduce her properly. She was with us on last year with her team, but one of the things that I love, and I hope, Christina, you'll take a moment to tell us a little bit your story about your journey. But Christina has been a nurse for more than 20 years, focusing primarily on leadership and on innovation in the areas of palliative care and hospice care and population health. She also has had some work with pediatrics. And so in 2022, Christina also joined MUSC's palliative care team, and she's the program manager for the Charleston division and serves as the executive director for the palliative care for the MUSC system. And in her role, she works very hard to ensure that we are able to increase access to quality palliative care across the state, wherever MUSC is seeing patients. She and I had a robust time on our prep session. And listen, we've got a lot of things that she's going to touch on that came out of that session. And so, Christina, I'm going to turn it over to you. Thank you again for being with us this week.
Thank you so much, Marisette. It's great to be with everyone. I'm always excited to get to talk about, what we're doing and hear what other people are doing to increase access to palliative care. Like Marisette said, I've actually been a nurse for 23 years now, and I have had various roles, but the majority of them for the last 16 years have been focused in hospice and palliative care and some type of leadership. Peds has always been my heart. That's as a practicing clinician, that's where I've spent my time. But I've loved to be able to broaden the scope and really look at palliative care across the continuum, not just in one particular age sector, but really how are we impacting palliative care across all age groups, because we know that palliative care is appropriate across all age groups. We have lots of people struggling with serious illness, and how do we help impact that? So I've been very fortunate to work with the team at MUSC. MUSC has been my medical home since 2003, except for about a 7 or 8 year period of time where I did some community-based work, which was just phenomenal experience. Also helped to start Hands of Hope, the children's pediatric program here in South Carolina, which was really one of the greatest joys of my professional career. So I continue to have a heart for peds work, but work with a fantastic palliative care team at MUSC, who really just at the base of what we do, which I think is true for for palliative care teams in general, is just that collaborative approach to be able to access patients and make sure that they know what palliative care is, that they have good access to that, and that their providers understand that as well. So one really exciting thing that we're working on, I was so glad for Marisette to reach out, is our integration into oncology. And just trying to be very intentional about that integration. We've been seeing oncology patients for quite some time, but how do we do that in a more meaningful way with a targeted approach? And we're going to talk a lot about that. And my hope for this presentation is that it's not a whole lot of me talking, but a whole lot of you all sharing your experiences too, and us being able to talk through that. So I'm not one who believes in death by PowerPoint, but I've got some things to talk through. And then I would love just to have conversation about what other people are facing, where they're seeing struggles. I think we learn so much from each other when we talk about where we see opportunities. So, all right, let me share my screen. And there we go. Okay. Is everyone able to see that?
Yes, we can see it, and also wanted to let folks know that they can put their questions in the chat, and we would certainly will address those towards the end. And when you take a pause as you're going through, Christina, I'll be checking the chat for the questions.
Sure. And always, please feel free to interrupt me. I cannot see the chat with the way my presenter view is, so Marisette will let me know, but happy to pause and answer questions if something comes up during the presentation. So it never bothers me to do that. So really what we wanted to talk about today is what are practical models for serious illness teams across various settings. Today in particular, we're going to talk about integrating palliative care with oncology. And this is not meant to be here's what MUSC is doing, and this is, the path everyone should take. I think what we know about palliative care and what we know about different settings is there's a lot of nuance. So really today is just meant to talk about where were we, where are we now, and what are we working towards, and what are some of the things that we've learned along the way. And so that's what I hope you all get from this today. So I think it's always important to look, where did we start? What was our footprint? How has that evolved? So in 2018, we started with a very small footprint. Actually, we had one advanced care practice provider in Hollings Cancer Center downtown. And we had a small percentage of a physician who was not in Hollings, but more seeing patients over in internal medicine. We had fellows who would see cancer patients also in Hollings on Fridays, but it was a very small footprint. And the other thing that I would call out is that our amazing APP, who is now on the inpatient side of our team, really was a one-woman show. She did not have support. So we didn't have a nurse coordinator. We didn't have social work except for in our fellows clinic. So she really was carrying the weight of just trying to get ambulatory palliative care to be recognized and utilized specifically within the cancer population at Hollings. In 2023, we really started to ramp up expansion of our ambulatory footprint. We hired in a very short period of time 2 APPs, 2 physicians who did 50% inpatient and 50% outpatient to make a 1.2 FTE of physician time.
Christina,
And
excuse me, I didn't know if you still wanted us to see your screen. We don't see your slides, so I don't know if you have slides.
I do, and I don't, hopefully this is not going to happen the entire time. Jessica, I may want to send you these slides just in case. My computer has been really strange lately where it kicks me off of meetings. It quit sharing my screen without me
Right.
actually doing that.
Why don't you send them to me, Christine, and I'll pull them up. And then if for some reason I can flip to it if need be.
Okay. Yeah, I've got to figure out. It's just started doing that, and it is very annoying because I will be in the middle of looking at something with someone and it just goes away.
Technology, I'm telling you.
I love it. When it works, it's amazing. All right, let's see. Yeah, here we go. All right, Marisette, I sent that to you and we'll try one more time.
Okay.
See if it works this time. Just let me know if it goes off again.
Okay.
And then we'll pivot.
I'm refreshing my email thing so to see if it pops up for me, but go right ahead. We could follow you, but I thought that you probably had something.
Yeah. So. Yeah. Okay. Are they back up?
Let's see. Yes, they're back up.
Okay, so again, in 2023, really started to ramp up overall ambulatory footprint. We really wanted to be also in other locations that oncology patients or patients in general were being seen. And we knew that although there was a big presence, obviously, in Hollings Cancer Center, there were also some off-peninsula locations that we wanted to focus on. And so we broadened our scope with more providers to be out in places like North Charleston and Mount Pleasant, so that we really are trying to meet patients where they are. The other really exciting part of 2023 is that we started a separate project that wasn't specifically focused on oncology, but it afforded us the ability to add a social worker, a chaplain, an RN coordinator, and a program coordinator to our ambulatory team, which I don't have to tell anyone who does palliative care is just transformative. You know, I say all the time, if you don't have an IDT, you're doing palliative medicine, and that's very different from really that all-encompassing palliative care that we all want to be able to provide for our patients. So currently where we are now is continuing to expand the bandwidth and have presence in multiple clinical locations. I would say the other big shift for us was the presence of telehealth. And so being able to see patients over video visit in their home. And I'll talk about that a little bit more too, because I do think that's an important call out from an access perspective. So why does integration matter? Why did we focus and are we currently focusing on not just being available to oncology patients, but really integrating with our oncology counterparts? Why is that partnership so important? So obviously anyone who does cancer care or takes care of cancer patients knows that it is increasingly complex. We are seeing very complex patients and medical trajectories. And like most things in our health system, can be very fragmented. And that's burdensome on the patients. So not only are they facing this serious illness, this disease process that is causing them physical symptoms, and the need for complex decision making, but they're also trying to navigate a very fragmented health system. And I'll just call out the partnership with the nurse navigators, because I saw several nurse navigators logging in on the oncology side for our palliative care team is vitally important. That help, that navigation, making sure we're making that connection for patients and families is only going to drastically improve not only their experience, but just their perception of care as well. And we also know that what we strive to do in palliative care is really address those system gaps. So how are we helping patients plug into different areas of the system to improve their experience, make sure that their voices are heard, advocate for what's important for them. Because along with that comes this caregiver strain that certainly is not stagnant. It evolves over the illness course. It becomes more cumbersome as that patient that the caregiver is caring for, as that disease progresses. Are we still doing okay with slides?
And you see that I switched over to my slides?
No, but that's great. Thank you. I'll come off of my screen view. That's actually probably better.
Can you see them?
I can see them. Thank you.
Okay, great.
Thank you. All right, let me make those bigger. Okay, so again, I think just to bring home, it's always important, and I think anytime I talk about palliative care, I always like to touch on making sure that we're countering common misperceptions, because we can never take for granted that anyone that we're talking to, and I'm not just talking about other providers or care teams, but also patients and families and the community in general, of understanding what is palliative care, because it very much gets conflated with hospice. And although we share a mindset around focus on quality of life and symptom management, the misconception that hospice and palliative are the same is really a limiting factor to access, because many times teams, whether oncology or cardiology or whoever, think, oh, it's not time for me to refer my patient to palliative care. They're not dying. And so really understanding that palliative care is not end of life only. This integrative palliative care model within oncology specifically, I think that's a really important call out for the oncology population, is that patients don't need to be dying to qualify for palliative care. And it can be delivered along disease-directed treatments, that it is longitudinal support across settings. These patients, and anyone who does oncology, I'm not telling you anything that you don't already know. These patients and their families face so much during this illness trajectory, even when we have good outcomes, even when we see patients go into remission or go into survivorship. We see patients and their families really struggle during that trajectory. And so understanding that palliative care is not prognosis based, it really is about patients dealing with serious illness and the needs that they have during that illness trajectory. And so I think that's always an important call out when we're talking about palliative care in general, but also why it's so important to integrate within these different subspecialties. All right, next slide. So a core integrative model, there we go, is what we are trying to do is twofold. So we may not always be able to go in and see patients. And I would say in our current practice, this is not what happens. We don't go in and see patients with the oncologist. And if you ask some people, a truly embedded model, you think of a multidisciplinary clinic where the patient sees multiple different groups during the same clinical episode. But that doesn't always work. And so I think the real bring home here is the relationship and the trust between the two teams. And so when we talk about ambulatory palliative care, embedding in oncology, sharing a space has been really important to us. It allows that bi-directional learning that happens when you have two different provider groups together, really to say to each other, here's what we're seeing when we meet with the patient, or for the oncology team to hand off the patient to us to say, here are the things that this patient has been experiencing, or here's what we're hoping you can help with. That transitional care support is very important, especially when you're looking at a patient coming from inpatient to outpatient. How are we helping them transition from whatever's been happening inpatient, whether that's treatment focused or they just received a new diagnosis, whatever that may be? How are we helping them to transition over to this ambulatory care setting, continuing to seek disease modifying or curative treatments, and also have a team that supports them along the way alongside of oncology? And that high level symptom management need, not that oncologists can't do that, they absolutely can. But what we know is they also need support, not from the ability to be able to do it or not be able to do it, but they have lots of patients to see too. And so really sharing the responsibility of the ongoing access between visits, that high level symptom management need, just that continuity of care, I think is another core piece of why this integrated model is so beneficial. You can go to the next slide. So what we strive to do in that integration is really to have that bi-directional communication. We want to align with where is oncology, what workflow, what disease modifying therapies are we focused on, what does the patient know about their illness trajectory. Certainly from a patient experience standpoint, we try and coordinate visits with treatment schedules. So we don't want to add burden to patients to have to come and see a palliative care provider. Certainly we want that to be a benefit and not a burden. So how do we help to coordinate visits? And I touched on this a little bit before, but what I'll say is, and call out, is that 70% of our palliative care patients are seen over video visit. And that's not necessarily because we only want to see patients over video visit. It is that patients have a lot on their plates. Their caregivers have a lot on their plates. And so if we're able to let that patient be at home, let them see a provider, have these goals of care conversations virtually rather than having the burden of getting in a car and driving to a clinic space. We want to be able to do that. And we really think too, it helps with patients coming to visits. You know, if we are making it easier for them to access us, we're more likely that they're going to show up for their appointments, and we're going to have a good finger on the pulse of what's going on with them.
Christine, I just want to pause here for a moment
Yeah,
because there are a few things that you said that I thought, oh, we need to catch it while it's going.
yeah.
The first thing when you talked about was the messaging, and how the messaging can either hinder people from, receiving palliative care, versus, staying away from palliative care. And so if you
Mhm.
could sort of talk about what kind of messaging have you been giving to patients and caregivers that makes this seem like it's a win for them to have palliative care along with their oncologist.
Yeah, that's a great question. So, I think there's a lot of work in the space of serious illness communication that's happening because that also is two-sided. I think it's really important for us as the experts in palliative care to also give other teams these same tools of introducing palliative care that we use when we introduce it to patients and families. And mostly that revolves around using non-threatening language and calling out to um, the common misperceptions, helping patients and families understand it's okay that you are confused about the difference between hospice and palliative care. So many people are confused about that, but let me help you to understand what is the difference, and helping, usually using that needs versus prognosis statement, saying, on whatever level it needs to be delivered. This is not about your treatment not working, or
Mhm.
um, the, you know, that we aren't going to continue to aggressively treat this cancer. We're not going, this has nothing to do with that. This really is a supportive team that's here to support and walk alongside you while you are going through treatment, because there are a lot of things that come along with treatment that do impact your quality of life, that do impact your symptom burden. And so I think the biggest hurdle is helping people understand that this does not mean that they are dying, that
Yeah.
it is truly about living well, and not that this is an end of life conversation. Uh,
Yeah, so it's talking up the benefits
yes,
as opposed to when you made the comment about it's needs based, not prognosis. We know that hospice is truly based on the prognosis, right? That this person has 6 months or less. So
right.
that's out there. And so when we talk about the needs, we're talking about talking up the benefits of how we can help you, enhance the quality of your life while you're being treated. And
Yes. Yeah.
so that message then, flips, and it causes people to really, and it's going to take a long time for us to do that. And I like the fact that you said that every clinician has to be on the same page about how to introduce palliative care. So that there's that part. And then the other question that I wanted to ask you was you talked about being in the space, and that in the same space as the oncology team, and that fosters trust and builds the relationship. And can you
Mm.
give us sort of some things that you guys have done while you're in the space with the oncology team that has really fostered the relationship and trust?
Yeah, definitely. I think, first of all, it's just accessibility. So if someone is sitting in a shared clinic space, there's going to be organic conversation that happens. Um, and eh, there's so much education that happens in organic conversations. And that's why I say it's that bi-directional learning. It's not just education for the oncology teams about what palliative care is, but also the unique challenges that oncology teams face that we are then aware of. Because truly, this is about patients and families, but this is also about supporting teams that are taking care of these patients. And so for us, it's been that visibility. Even though we see a ton of patients over video visit, we're very intentional about having in-person dedicated time in these locations. From a leadership perspective, it has, and I'm going to touch on this in a minute too, but it's been wildly important that we are also having leadership to leadership conversations on the oncology side and palliative side. So helping leadership in these areas understand what is palliative care. Like we can't expect the trickle down effect if even the people who are helping lead oncology teams don't understand what palliative care is. And so, and also, do we have the same mission? Are we moving on the path for the same reason?
Mhm.
Um, and so, you know, what is important? This is why the leadership conversation is so important. So what's important to our oncology teams? What is going to help them provide the best care possible to their patients, and how does palliative care play into that? But I think from a very simple foundational standpoint, it is the visibility piece. It is, you know, it's the old adage of out of sight, out of mind. What we
Mhm.
know about embedding is that we could hear conversation about something and it triggers for us in our palliative brain, oh, that's a palliative care patient. Well, that patient is really let me tell you what I just heard, because that patient is really appropriate for our service.
Yeah.
And, you know, when I think we all know, I started off as a NICU nurse, and I was only focused on all the things to take care of that baby that I needed to. I wasn't thinking about the extra things that I, you know, might have access to. I was just very focused. And I think that's very true of all specialties. You are very focused on your specialty and what you're doing for that patient, which is wildly important. This is why, yes, we can use, and this slide speaks to that, like, yes, we can use disease and treatment specific triggers. Those are also very helpful and very important. You can use routine screenings and needs assessments. All of these things can drive appropriate referrals to palliative care. But I really do feel strongly about that shared responsibility with the oncology teams, just to walk alongside them and say, hey, I heard about this patient, and this patient will really benefit from palliative care. Is there a reason that we aren't seeing a consult for them? Are there some things that we could talk through that might make you feel better about referring that patient to palliative care? So I think it's that relationship and visibility that's
Mhm.
just wildly important.
Hmm. Well, I probably, and you're probably going to speak to this, is that when you do that, you have the outcomes too. So the
Yes.
outcomes also drive the trust as well. So when they've given you a patient and their caregiver to help them with their needs, and then they hear back about how that was so beneficial for them, that also helps. That we don't want to play that down, that you're getting results, and that gets back to that team as well. So to enhance the trust level.
Yeah, it's the sliver effect, right? If you can get in a little bit and take care of one patient and do it well, it is a trickle effect. Then that
Mhm.
sliver of access gets so much bigger because you see the benefit. And so yes, I mean, we anecdotally know in palliative care the impact that we have, but I think our struggle has always been, how do we demonstrate that to others? Of course, you have the wonderful qualitative feedback that you get from patients and families, which is so highly impactful. But you know, there's a metric piece to this too, and I think we're trying to work harder in palliative care to really use those metrics to paint the picture for other people who might have a misunderstanding about what the impact of palliative care looks like. And two, I think just to call out that it's not a good thing to have. It's actually evidence based. It's a proven specialty that impacts quality of life, patient outcomes, and so, you know, it's a standard of care. It's not just the right thing to do. It's actually what should be the standard of care for patients. So, Good to go to the next one or any other?
Yes, I'll try to hold back a little bit
No,
too.
don't. I love it. I love better than anything just a conversation because I think that's where the real pearls come out of. So, one piece that we call out, and I spoke to it a little bit, but this post-discharge support. So this is something that we're actively working towards. We see the real benefit in when patients are transitioning care between settings. This is where most of the time the gaps occur and patients fall through the cracks, and then they have to come back to the emergency room because their symptoms are not being managed or whatever may be happening. And so really that post-discharge support is something we're actively working towards, looking at having a transitions clinic to see high need patients in a short and frequent amount of time that, given the current bandwidth, might not happen in a standard palliative care workflow, so that we can have this continue to augment this rapid response to symptom escalation. We also feel like, too, I can't advocate enough for early involvement of palliative care because we want to see these patients when they're doing well too. We want to build the relationship when the fire is not going on in the house. I don't know if you have not YouTubed palliative care fire department, it is, as a palliative care provider, it's maybe one of the funniest videos I've ever seen because it is so wildly true and illustrates just what I'm talking about, because we get called in many times very late for these patients and we haven't had the continuity with them. And then we're also asked to not have goals of care conversations like, no, can you just help me manage their symptoms? I don't really want you to have a goals of care conversation, and just helping people to understand, like, you can't have a goals of care, or you can't do symptom management without having a goals of care conversation, because I got to know what's important to that patient and what symptoms are burdening them the most to really have an impact. And so anyway, I highly recommend looking up palliative care fire department. Really funny, like animated video that I think encapsulates that well. And I think the other thing we want to look at and we want to impact too, and we have seen impact in, is this reduced avoidable utilization. And I think that avoidable term is really important there because there are still very appropriate hospitalizations. There are very appropriate utilization pieces. But there are absolutely things that are avoidable if you have a really strong team that's walking alongside these patients, somebody that they can reach out to, that they know they have that rapid response to symptom escalation, that they have somebody to talk to about what's changing for them, what needs are changing, not just medically, but also psychosocially. How are we looking at their determinants of health and what's impacting them individually? That doesn't have to do necessarily with physical symptoms, but all of the other symptoms that come along with serious illness care. So I think that transitions of care support is also really important.
Yeah, I think about those social drivers. If you have a caregiver who has to work and they're having to take off from work, and so they may not have, PTO days like some of us have. So when
Right,
you think about that, they're losing revenue, which the household needs. And so,
right,
they're looking then at the virtual visits helps with that kind of thing. We may not connect the dots, but that also helps, because if you can do a virtual visit in the evening or on
right.
the weekends, then you're helping that family be able to manage what they need, during the week if there's a financial situation.
Yeah,
And so I think that's one of the things that I've always thought about, is that we often want people to function in the 9 to 5, but families don't always function in the 9 to 5. They may have a job that's a afternoon job that is from 2 to 10, or there may be
right.
other things that are going on. And so really having the ability to dig down into the issues helps you really to provide that support along the journey. So yeah.
So true. That's so true. So I did touch on this a little bit in 2023. We were so fortunate to add an IDT to our ambulatory team, which is just been transformational, I think, for us. Of course, it's done the thing of we knew what we didn't have, and now we have it, and now we want more. And so that's my job, is to, advocate for that need. We need more social workers. We need more chaplains. We need more nurses. They really do make a difference in the care that we knew that, but it's good to see just the fruits of that come back, and just the feedback from patients and families overwhelmingly, and the support that they received from the interdisciplinary team. So our team specifically is palliative trained physicians and APPs, also palliative trained social workers and chaplains, and our nurses as well. And really, again, just calling out the nursing coordination piece, I think, is super important. The collaboration with the oncology nurse navigators is very important. Making sure that we're lockstep in what's happening with these patients is vital. And then our next goal is to have a pharmacist who's focused on palliative care available to our patients and to our team as well. So that's next on the horizon.
Oh, I love having the pharmacist piece. That is
Yeah.
really good.
All right.
So
We can go to the next one. So I touched on this a little bit, but I'll just hit this point again. What we have found, which has not always been the case, so I think I should call that out too. I think I'll go back to the it's a nice thing to have, but it's not a standard of care. So there has been a lot of change across the oncology landscape that has really necessitated the conversation around standard of care. At the end, I'll touch a little bit on what we've seen with the enhancing oncology model, but specifically at MUSC and our oncology groups desire to reach the next designation really brought palliative care to the table, because it's being recognized as a necessity to accompany oncology care, specifically in certain sections of care, whether that's GYN oncology, just some specific disease process areas that have been called out, certainly. And it really did need clear leadership buy-in from our group, as well as senior oncology leadership. And I will just say that we are very fortunate that we have a great collaborative relationship with oncology leadership, and their recognition that palliative care is a standard of care, that it is the best thing for their patients and families. And that it's something that we need to support. And so that shared system ownership too, as we are seeing Hollings and the cancer ICE, as we call it at MUSC, move across the state. So we'll have a center in Orangeburg and one in Florence and one in Charleston. That is the designated centers across the state. We needed a system approach to make this happen. It wasn't just let's focus on Charleston, which tends to be our hub, but really focusing on patients in South Carolina who are seeking their care within a Medical University of South Carolina location is the same access that they have to palliative care in Charleston, the same access they're going to have in Orangeburg and they're going to have in Florence or the Midlands or wherever it is they might be walking through the door. And so really looking at that alignment of staff and space. How do we coordinate scheduling, all of those, operational pieces, just making sure that we are in tandem with our oncology partners in this. And so it's been a lot of really great conversations. It is not easy. Like, I will not paint the Pollyanna picture for you that it was just magically happened. It has taken a lot of conversation, and it's still a work in progress, but I feel really good about the conversations that are happening. They're very collaborative. So we're definitely on our way to making that happen. So I think too, as we've worked on those pieces, understanding that the clinical workflow design needs to be predictable. It needs to be predictable for the oncology teams. We need to have a defined follow-up cadence. We also need to make sure that people understand that we are flexible from an in-person and virtual care perspective. So, a lot of times what we hear as a limiting factor up in Florence is, well, gosh, my patient can't drive all the way to Charleston to be seen by you. So making sure that we're clear that we don't have to see them in an actual clinic, that we can see them over video visit. We can help, to set that up. And so I think that's been another education piece as we've moved across the state, is just making sure that everyone's clear on how we can see their patients too, not just that we can see them. Next slide.
Oh, let's see. I'm getting stuck. Hold on. I'm going to get it. I looked at there. Did I get it? There.
Yeah, there you go. And I think Marisette touched on this earlier. It's also important to be able to measure and show the impact that we're having. So, how well are we managing symptom control? Are we having goals of care conversations that elicit what quality of life is to that patient and their family? Who's owning the advanced care planning? Well, is that the $1 million question or what? Because, long gone are the days of thinking this is just a piece of paper that I fill out and don't look at again. This is an evolving thing, and advanced care planning is not a one-time occurrence. It's something that really has to occur during conversations throughout the illness trajectory. And so helping teams own that's a huge piece of just making sure that patient voices are heard. And so, palliative care takes a huge role in that advanced care planning piece. Also, the care of the caregiver, what's going on with that person who's providing that care? Do they have a work schedule that is not conducive of getting their loved one to these clinic appointments? And can we help by doing virtual visits? What are we doing to help the caregiver as well? And then I think, I probably will always be a hospice nurse at heart. I don't think that will ever go away. Utilization and end of life quality is highly important. And what we see many times is getting patients at the appropriate time over to a hospice team to provide that level of care does not happen well. There are a lot of limitations in getting patients over to hospice when it's appropriate. And so, again, I think that goes to earlier conversations in palliative care of really paving that road. If we know that eventually this is likely to lead to a hospice appropriate patient, are we setting up
Did the water company ever come? I think so, because
hold on just a minute. There's someone who needs to mute their phone. And so if you could do that for us, we really would appreciate it. Thank you so much. Christina, when you talk about the hospice piece, I think, yeah, that there's a need there for the collaboration on that end of it. And so much sort of goes into that, depending upon, are they a Medicare hospice, Medicaid hospice, or is it a commercial payer, and those pieces, but also the caregiving piece of that. And so I think that definitely is a piece that we could have a conversation about at another time. How do we work on that to make that better? Because families should have access to a good transition and be able to, have the hospice piece. So you can tell I'm an old hospice nurse.
Yes. Yeah. You can spot us a mile away, Marisette. All right, we can go to the next slide. So I said I would touch a little on enhancing oncology. So this is a model that's being driven by Medicare or CMS to look at really how are we enhancing the care of patients who are dealing with cancer. So it's a coordinated policy and payment framework that really emphasizes that whole person coordinated cancer care. One of the EOM utilization goals is early palliative care. And so how does getting a patient involved when it's appropriate with palliative care, how does that improve their quality and also the utilization goals that are associated with enhancing oncology? Advanced care planning and symptom management are also core expectations of the enhancing oncology model. And like we spoke to before, especially around advanced care planning, sometimes it is this misnomer that it's a one-time conversation. You kind of put it away and go on. But really, especially when you're talking about a care trajectory that very much evolves over time, these advanced care planning conversations are important over time and not just in a snapshot. And of course, we want patients' symptoms to be managed. So, are we managing their nausea? Are we managing their pain that might be associated either with their cancer or with treatment? So really looking at high level symptom management and how patients are receiving that. And really, if you look at what the enhancing oncology model aims towards, it makes total sense that an integrated palliative care model supports this practice success. And so really, again, it's so important to have that relationship between the two teams in order for this to be successful. And in the end, I think who benefits from that is the patient and the family. So, yes, oncology is going to feel supported and palliative care is going to feel utilized, which we always love to feel. But at the end of the day, the real benefactor of this level of care is the patient and the family. And so just don't want to ever lose sight of that. This is not about, palliative care getting more patients because we like to have more patients in our practice. It's really about making sure that people are getting access to a level of care that's appropriate for them and that will impact their quality of life and just their overall experience of care. And so never want to lose sight of that. So we can go back to we can go to the next one. So how is this applicable across settings? Palliative care doesn't need to just happen in an academic medical center. Certainly, we have tons of friends across the state who are doing amazing palliative care work. We just had our conference, our HAPC conference in Columbia, and it's always such a good time to see just our friends that are doing palliative care and doing amazing work in places like Prisma. And so, integrating not only in, large health systems, but also community oncology practices, utilizing rural and telehealth models to reach more patients. Thankfully, because of technology, we can reach patients where they are and not expect them to come to us. And so I think that's an important takeaway as well. So all of this summed up is really that early integration improves patient and caregiver outcomes, hands down. It is, we have continually looked at information on the importance of early palliative care consults. And it is glaringly obvious the positive impact that has. Introducing our teams earlier in the disease trajectory takes down barriers that this is end of life care. Because what perpetuates that verbiage is the fact that we get patients, and when we get these patients, they're actually very hospice appropriate patients. And so it would make sense that if we are referred that patient in a hospice appropriate period, they're going to look at palliative care and say, you're a hospice team. That's what you're doing. And so we're perpetuating this misnomer by not utilizing palliative care earlier on in the trajectory. And it just is more impactful when we're able to start small and build presence as that patient needs it. I think that's the other thing. This is not to be burdensome and have more visits for patients. This is to be available, that when things are starting to ramp up, when that disease is starting to evolve, that we've had interactions with that family and that patient already. Again, leadership and workflow alignment are essential. Communication is at the core of everything we do. And so you can't have good collaboration without good communication. And so making sure that we are meeting regularly to talk about what we're working towards, where are we seeing gaps, how can we improve continuously. So that leadership and workflow alignment, I can't emphasize that enough. And I think sometimes this seems very big, and it can be. There's a lot of patients who need to be seen. And so sometimes it's paralysis by analysis, like, oh gosh, how do I even start this? And so really being intentional, start with an intentional focus. Even if that is small, it's more than what's being done, right? So you got to start somewhere, and starting with a smaller intentional focus, iterating that, showing outcomes, building partnerships, it will only continue to grow. I think the biggest problem that we're having now is that there's a lot of patients that need to be seen, and we need more providers. Like, we need more people, we need more teams to see these patients. And so it's a great problem to have, in that we know the need is there and we want to meet it. But even if it's got to start small, that's better than not starting at all, is what I would say. And so just, doing that intentional focus and building those partnerships is vitally important. So that is all my slides. So that leaves us some time to talk, to bounce things off of each other. So Marisette, I'm happy to open it up for whatever you feel is best next.
Wow, Christina, this has been a wonderful overview of how you are systematically looking at this, not just from a department perspective, but how you've integrated this, and that, of course, there is leadership buy-in, that we have to have this service. So then you can begin to look at the systems approach. But I do like that you gave us hope at the end, that just start somewhere. Find out where the gap is, and which gap do you want to address first, and make inroads there. So we want to open it up to see if anyone wants to share what you may be doing in your neck of the woods. Or if you've got a question, feel free to put your camera on, unmute yourself. We can't tell if your hands are up, but or put your questions in the chat. That would be great. Any questions for Christina? All right, you did such a great job. I don't see any questions in the chat.
One other thing I would say in the vein of starting small is figuring out who your champions are. I think that's definitely how we started too. We had several oncology providers who were palliative friendly, I guess I would call them, and very much recognized what it was that our team did for their patients. And so we started with them. We just built that infrastructure by seeing more of their patients, and the word spread. And that's, I think that really helped the momentum. And then it also helped us to get into these leadership conversations around what could this look like from a larger scale. So find your friends and utilize them, partner with them.
Very good, very good. I love it. We can definitely get further along when we have partners. We can't do anything in isolation. So very good. Well, we want to also share with you that we want your feedback. And so we are going to put up the QR code for our evaluation. You can either scan the QR code, we'll also put it in the chat. And we want to invite you to be with us the rest of the week. Certainly on tomorrow, we're going to have 4 of our guests with us, and Dr. Tracy Fasolino is going to be our moderator with our esteemed panel. We have Dr. Michelle Malika, who will be joining us to really talk about survivorship across the care continuum. We also are going to have Dr. Natalie McAndrew, who's also a nurse, and she's going to really be talking about the family engagement piece and what that looks like, and also some work with pediatrics. And then Michelle Vondermoss is going to be with us, and she's going to really bring in the child life specialists perspective and the work that they are doing. And then we also have Dr. Janice Withcomb, who's going to be with us, and she is going to really talk about physical activity and some of the research that is out there in terms of oncology care, and really looking at those pieces as well in terms of physical activity, symptom management, and looking at how we deal with fatigue. So really going to be a great lineup on tomorrow. You don't want to miss it. And of course, we'll be continuing on Thursday from 12 to 1:30, as well as Friday from 12 to 1:30. So there's still time for your folks to participate. If they weren't able to make it today, they can absolutely register and get in on any of the discussions and conversations that we're going to have on the rest of the week as we dive into our theme, collaborating to transform cancer care. So those are the things that we have for you. We're going to give you a little bit more time back into your day, which is always a plus, right? And once again, Christina, this was amazing overview, really great nuggets in terms of how we can expand our work, and that embedded piece we're seeing happen in other areas as well, with heart, with pulmonary, that oncology, that palliative care shouldn't just be a standalone, but definitely needs to be embedded. And so appreciate you sharing with us those nuggets about oncology embedded palliative care. So guys, with that, we're going to let you go. We will see you on tomorrow, and have a great afternoon.
Thank you all.